Welcome to the Trauma Treatment Collective vlog. Today we're going to be talking with Dr. Cohen about treating trauma with medication. She's going to be sharing some important information with us, so stay tuned.
All right, thanks Dr. Kunam for being willing to be a part of this vlog and talk a little bit about medication and specifically medication and trauma treatment. We connected via social media, which I've already talked about a little bit in my intro, but yeah, just connecting and commenting back and forth on each other's posts and stuff like that. And like I was telling you, in the Trauma Treatment Collective Facebook group, we were having a conversation about modalities and treating trauma with medication. And it's just a topic that I don't know a lot about. I know how to make a referral, but once that referral happens, I'm not quite sure what happens after that. I stay in contact. I give some information, but I'm sure my information could be a little bit better. So anyway, as I'm learning, I thought I would bring the community on to learn with me and be able to kind of better their referrals as well as their connection with their psychiatrists. Because I do believe that trauma can be treated in therapy, but sometimes for some clients it can't be. That can't be the sole thing. Like there have to be multiple avenues of treatment, and one of them definitely is psychiatry. So tell us a little bit about yourself and how you practice and where you practice and just anything you want to share about yourself.
Okay, great. Yeah, thank you for inviting me to do this. I think it's important to kind of keep an open dialogue with between therapy and psychiatry. They're so, they're interlinked so much. And really, truly, a lot of my patients, I'd say 90%, they have a therapist or I recommend a therapist in addition to using my services for medication management. So my name is Dr. Kunam. I trained in Michigan at Henry Ford and currently practicing as a board certified adult psychiatrist or general psychiatry. I do see adolescents and adults, and currently doing almost 100% online telepsychiatry. So I do outpatient work, medication management for therapists that refer their patients to me, and I refer patients to therapists, and then I do consults in the hospital through telepsychiatry as well. So I currently have patients in Michigan and patients in California. So it's kind of a new modern way of practicing medicine.
Yeah. Are you finding that clients are enjoying having that telemental health or telemental health? I don't know what they call it in psychiatry.
Yeah.
Anyway.
Different terms: telepsychiatry, telemedicine, telehealth. But yes, they really. I'd say that even some of my patients that are not very technologically savvy, they will have their grandkids, set it up for them, and I'll say hello, and they'll say hello, and they'll leave the room to give their grandparents some privacy. But they do seem to like it overall. Generally, a certain generation, are very familiar. They're almost more comfortable with telepsychiatry than in person almost. So it's not for everybody. It's definitely has some limitations, but then it also takes away some limitations. So I really do enjoy it. And I think it's a great, additional service to offer a lot of people.
Yeah. So when we're talking with clients about medication, what are some helpful tips that you can give us to help clients kind of get ready for a medication evaluation if we're thinking about referring them?
Sure. Yeah. So number one, just showing up to the evaluation is probably the number one thing. I know a lot of my patients will tell me like, "Oh yeah, I thought about it. My general practitioner, my PCP told me, but I kind of put it off, or my therapist mentioned it, but now things have gotten so bad. Now I'm here." And then I say, "Okay, well, I'm the right person to help you with this," but really coming in, also knowing that we're not here to force medications. We truly are doing a full evaluation just to understand are medications the right additional, therapeutic modality, and then we talk about it. The risk factors, the benefits, and then we talk about particular symptoms. What has been the main issue that maybe therapy hasn't been helping with as quickly as you would like, or maybe it's so severe that therapy is helping a little bit but not enough, or timeline, trying to get back to work, trying to get better sleep, but just basically taking the first step to get in, because it is a long wait to see a psychiatrist. So when you cancel, you've got to wait almost another 3 months, and so that's probably my number one kind of tip, is just walk in through the door.
Yeah. And I definitely tell them, I said, look, let's go ahead and get on somebody's wait list. You still will have time to think about it, time to, ponder. And if the appointment comes up and you decide that you don't want to go, then that's okay. But I think that piece of just almost preparing them that, hey, there's going to be a little bit of a wait. This is not like a, go make an appointment, go tomorrow kind of thing. But there's a wait. And so I kind of, when I start thinking that clients might need this, I go ahead and try to get them on somebody's wait list and then continue to keep having conversation about it. And do that kind of thing. Okay. Any specific things they need to bring to the appointment or have with them or anything like that that you find that clients may not have access to or may be rifling around in their stuff to get those kinds of things?
Yeah. So definitely bringing a medication list of current medications that are being taken for other medical conditions like blood pressure medications, diabetic medications. Sometimes just bringing the bottles in with you or getting a printout from your pharmacist might be a good way, like at CVS or wherever you're going, having the app available on your phone to look through it. Those are different ways that I try to have the full list. If you have a doctor that's in the same system, like when I worked at Henry Ford, if the general practitioner was also in Henry Ford, I'm able to pretty much look up the list, and so it's a little easier. But still, sometimes current lists are hard to come by because different pharmacies and whatnot. So I think that's the main thing, is just for us to understand what medications currently on, the dosing, the time of day. So if somebody is coming and doesn't really manage their own medication, sometimes like it's their spouse, sometimes I say bring your spouse, because or bring a list in that the spouse makes for them, that sort of thing. And then if they happen to have an idea of maybe if they had seen a child psychiatrist, trying to get an idea of talking to their parents, again, an idea of, why did I go to a child psychiatrist? Was it for possibly ADHD suspicion, and was there a medication trial, and that sort of thing. So maybe getting information from family members. And the other thing is sometimes bringing somebody that they're close to that can really kind of offer their opinion on what's been going on, that they trust, that they're okay with that person being in that appointment, at least for a brief period of time of the appointment.
Yeah. Okay. All right. Excellent. Then as you're thinking about like the medications that are commonly prescribed for symptoms of trauma, so for that anxiety, anxious presentation as well as that depressed presentation, what are some common ones that you kind of see or that you prescribe for clients who are struggling with trauma symptoms?
Sure, yeah. So one of the most common is what we call an SSRI, or a selective serotonin reuptake inhibitor. And it's basically a medication that we use actually for both the depressive symptoms and the anxiety symptoms. And it's taken once a day. It's usually taken in the morning. They're very well tolerated. They tend to have very few side effects, and the side effects that do come along tend to be kind of easily tolerated. And some common names, like the generic names, are escitalopram, which is Lexapro, fluoxetine is Prozac, citalopram is Celexa, and sertraline is Zoloft. And they're taken for many different things. I mean, there could be somebody with a migraine that takes sertraline, which is Zoloft. There could be someone with PTSD, somebody with panic disorder. So they're used quite commonly for many different things. Many people with jobs, families with lots of responsibilities take these medications because they don't cause a lot of sedation. They really make people function better rather than it bogging them down. So that would be one of the first, what we call first line treatment. And then in particular, when it comes to anxiety, we may once in a while use a medication that's under the heading of benzodiazepines. They've been under, some kind of a target recently because when people use benzodiazepines every day, your body naturally does become dependent on it, even if you don't mean to become dependent or quote unquote addicted to it. So it is one that we use very cautiously now, but it's very helpful for sleep and panic attacks when you can't leave a situation, if you're at work or if you're somewhere, and just testing that medication out to see if it's helpful to like slow down that panic attack if you really need it, if you're not able to get out of the situation or you have to go back to work, and making sure that you're not overly sedated on that dose. So it's really important that the doctor kind of talks to you about that, not just borrowing it from somebody to use. And then the what I'll say is a non-benzodiazepine anxiety medication we use is actually blood pressure medications. And those we can use for even nightmares that are specifically related to trauma. And then during the daytime for panic attacks as well, or for anxiety. So because they don't cause much sedation at all. And you don't have to worry about your body becoming dependent on it the way that you do with benzodiazepines. So those are probably the three that we kind of focus on.
What are the commonly prescribed benzodiazepines?
Sure. So some that are commonly prescribed, one is Klonopin, which is a long-acting one, which you can take once every 2 days or once a day. That's how long-acting it is. And then there's Xanax, which we tend to use for very short periods of anxiety. So if it's, something where, it's just going to be a couple hours, or, you're just trying to slow it down or temper it a little bit, but you don't need it for long periods of time. And then Ativan is one that we use often because you can rely on its half-life very well, and it's about 6 hours. So you could take it at night for you to go to sleep, and you'll know that it kind of gives you a good night's rest, and you can wake up in the morning without feeling too groggy because it's not too long-acting like the way the Klonopin is.
Okay. Great. I was just thinking it might be helpful for therapists to know a little bit of those names if clients are throwing around, to kind of be like, oh, how long have you been on that? And just check in on that to make sure there's not any things to be concerned about. Okay, great. Thank you so much. So if a client is on medication to help manage their trauma-related symptoms, what are some things that we as therapists can be assessing from a week to bi-weekly basis to be able to report to the psychiatrist or share with the client to share with the psychiatrist, however that communication is happening?
Yeah, well, number one, that's great that, that's something that you are bringing up, because we do truly rely on the therapist for a lot of extra information. And so I would say that definitely looking for the negatives and the positives. So starting with the positives, what are some of the symptoms that are actually improving and by how much, and keeping track of it, using a scale. That's really helpful for us because generally the therapist will see our patients more often than they see us. And so we really appreciate that kind of feedback, even using a number scale, something simple like 1 to 10, and looking at things like specific symptoms related to trauma. So like, are there less dissociative episodes going on? Or, are there less avoidance behaviors? Are they getting better sleep? Or at least is it more restful, less nightmares, less night terrors, which are a little different from nightmares? And then even physical symptoms like body aches, body tension, fatigue. And then improvement of depression would be something like better interest in activities, more motivation and energy to do things, socializing more. And then, of course, the negatives of their side effects that they're talking about, complaining about. A lot of times we don't see a patient, sometimes we don't have it scheduled for another 3 months. And so they get lost in the whole side effects. They stop it. It's been stopped for 6 weeks. And then we see them, they're like, oh yeah, by the way. So encouraging them to tell us immediately so we can go ahead and try a different medication, try a different dose. Or sometimes we have to add on a medication if needed for that specific side effect, if the medication is actually doing what it's supposed to do and they're doing well, but there's this very annoying side effect. So I think that's probably the main thing, is just keeping track of what's getting better, what's not. And when it comes to benzodiazepines, kind of just being, kind of noting if they are taking it very regularly. Is there any anxiety being built up about not having the benzodiazepine? Because there can be that emotional dependence on it, even if there's not a physiological dependence. So kind of seeing how much they're taking, how often, and what their feelings are about the actual benzodiazepine.
Yeah, that brings up that reminds me of just working with clients who just feel like they need to have it in their possession, but they never take it. So it's that emotional connection of, this is kind of my thing. And so helping them to work with that's not needed, or, moving towards being okay without it. The other question I was going to ask that came up for me is kind of going a little bit back to medications is how long should we expect to see results? So like from the time a client takes a medication to when should we say, okay, if it's not working by this point, it's not working,
Yeah, that's a good question. That's another reason why that whole walking through the door, making that appointment, getting through is so important, because once they start the medication, like Zoloft or Prozac or Lexapro, they see, some symptoms can kind of get better within 3 weeks, but real remission or real significant improvement, it may take up to 6 weeks even. And if there's any OCD involved that's, maybe additional to their trauma-related disorder, that could take up to 3 months, actually, OCD, which is, really a long time. So I would say 3 weeks might be the minimum to see some improvement. But there are some medications that make people a little more relaxed as soon as they take it. It's kind of almost like a side effect of it, but they notice it immediately. So there are a couple things they might notice immediately. There's obviously placebo effect, which is not a bad thing. They know they're going to be taking something. There's some hope that's sparked, and they feel encouraged that they did something, moving in the right direction. So it's important to just kind of check in and see, was it a placebo effect and now that's waning, or is it really a placebo effect and now the medication is kicking in and they're actually doing better? So I would say 3 to 6 weeks is a general rule.
Okay. Yeah, great, thank you. When building a referral source, working with psychiatrists, any suggestions you can give therapists on what are some things to look for in a psychiatrist to know that they're practicing ethically and they're practicing with the most up-to-date information? Like just some things in your field that would be important for us to pay attention to.
Sure, yeah. I would say, when it comes to psychiatrists, which are MDs or DOs, which it's important to note that they're very similar in training. So DOs are a type of medical doctor that go to a specific medical school called osteopathic medicine. But those both tend to have very similar training, very similar curriculums. If anything, the DOs actually have a little extra training in manipulation of certain bones and body parts that we actually don't get that much training in. And nowadays the training is actually merged, like for residency, we get the same training for 4 years in psychiatry. So we're very, very similar. So I would say recommend for clients to not be shy in seeing a DO as well as an MD. Either one is fine. Again, most MDs and DOs, our training is so similar. Like we have this, a board that kind of governs how our training is across the board, across the nation. So for the most part, in the last, I'd say 10 years, all our training is pretty similar. Well, some of us might be better trained with schizophrenia in the sense that we see them more than maybe some that have used more electroconvulsive therapy, like shock therapy in their training. So they're more comfortable with that. But a lot of it, we're introduced to all of it. And so the doctor really, once they graduate, they kind of decide what they're going to use, what modality they want to be able to use. And then they'll also refer you to another psychiatrist, perhaps, if they think ECT is needed, or if they think TMS is needed, they don't have one in their office. But generally, DOs and MDs, they all have undergrad, and they have medical school 4 years of training with their counterpart, the surgeons, the OB-GYN, they're all in the same medical school learning about all the body parts. And then they go on to 4 years of training, hands-on in a hospital. So I would say very, very little variance other than maybe even the personality. So I think that's more important. It's kind of looking at, is this someone you're going to be comfortable seeing? Do you prefer female over male? Do you prefer the same ethnicity, culture? Those are the things I think will really impact the compliance, like kind of feeling comfortable to go and taking the medications, feeling connected, especially when you're only going to see them once every 3 months sometimes, so just to feel that trust. And so I'd say that's the important part. The other thing that can be kind of confusing is there are nurse practitioners that they do call themselves doctors because they get a doctor of nursing practice. And they're great to work with when they are under the supervision of a MD or DO, because they do have good knowledge of sometimes medications being used, what kind of happens in maybe a psychiatric hospital setting. So they have a lot of experience, but they don't have the 4 years of medical school that we had. So they have some courses, but a lot of times the courses are very generalized. So they're really looking for the psychiatrist to train them in psychiatry and kind of get that knowledge from them, and then to ask questions from the psychiatrist when there's anything that's kind of complicated. So just to know that if that's the person that they're saying you're going to see the first time, it's okay. Ask for an MD or DO, or first see the nurse practitioner, and then if you feel like they're really communicative with their psychiatrist that's supervising them, that's okay. That's a good nurse practitioner that's kind of using their knowledge base wisely.
Mm-hmm. Okay, awesome. Thank you for that. That's very helpful. And let's see, anything else you think might be helpful that we didn't talk about that it was sparked for you? And if not,
sure. I think, for the most part, it's really just, I think encouraging patients to feel comfortable to see a psychiatrist. It doesn't mean that they have to see one forever. It doesn't mean they have to take a medication. And really just kind of taking that first step. So at least there's a psychiatrist that they know. So even if down the line, let's say something happens, things get worse, or, whatever it is, then they know that there's someone that they've met before, that has seen them before, can kind of follow up with them. And I think that's pretty much the main thing. For the most part, we will do the medication management, but we'll also talk about when to stop the medication if that's something that is, possible. And then as far as, understanding different modalities like TMS and ECT, they're the ones that are going to be the only ones that can offer that. So really kind of at least talking about it with a psychiatrist, understanding what it is, those are all things that are worthwhile for a client, I think.
Awesome. Thank you. So share a little bit with us if people want to connect with you. Maybe we have some California people who are looking for psychiatrists to refer to, or some Michigan people, or maybe there's some other services that you provide. How can people connect with you?
Sure. Yeah. My website is my full name, md.com. So Neelima Kunam, md.com. So it's NEELIMAKUNAM, md.com. And then I practice with Oakland Psychiatric Associates in Michigan. So I take insurance, different insurances, both in Michigan and in California. My California practice is Inland Psychiatric Medical Group. So if they want to Google either one of them, but you can go to the website and sign up on the website itself to do an intake form. And then usually, within a few days, we'll get back to kind of talk about what's appropriate, what's not, or if a referral is, recommended. And, in California, we do offer TMS. It's the transmagnetic stimulation, which is great for depression. It has some new indications covered by insurance very well, actually. So that's something that is helpful. It's strong magnets that actually manipulate parts of the brain to help with depression, help with anxiety, that sort of thing. So it's very easy. Some of them are 15-minute sessions where they just place a magnet on top of the head, and that's something that has shown to improve symptoms when sometimes medication doesn't. When it comes to other services, for the most part, ECT is done in a hospital setting. So we would refer you to a psychiatrist that does that in a hospital setting, or a different type of clinic setting.
Awesome.
Yeah.
Thank you for sharing. I will definitely link all those things in the description so people can quickly click on whatever they're looking for, so make sure that they can connect if that's something. And just want to thank you for your time. Thank you for your wisdom and your knowledge and sharing it with us, and doing it in such a way that's so easy to follow. So I appreciate that.
Thank you so much. I really appreciate you inviting me to do this. Anytime.
No problem. Thank you.
All right. Bye.